Right, I think we're at a quorum, so we'll get started. Before I do anything else, including introductions, I would just like to acknowledge the traditional owners of the lands and waters on which we live, and from where we're all meeting today, which will be many and varied. I pay respects to elders past, present, and emerging, as well as to any Aboriginal and Torres Strait Islanders who might be with us in the audience today. When I'm in Australia, home for me is Gadigal land, but I'm coming to you from overseas today. I'd also like to acknowledge just what a difficult few weeks and months it's been for Aboriginal and Torres Strait Islander friends, colleagues, and communities, with the yes and no campaigns ramping up for the voice, and 3.8% of the population effectively depending on the other 96.2% of us to do right by their communities. And some of the divisive language and rhetoric that has been prevalent across social media and the harm that has done. I personally am voting yes because I believe in self-determination, and that might be a topic that we touch on today because it's very relevant to addiction too. And from the data that I've looked at, 80% of Aboriginal and Torres Strait Islanders support the voice, so I want to support them. Okay, across to introductions. So I'm Pia Clinton-Tarestad. I'm one of the co-founders and the CEO at Clean Slate Clinic, which is a virtual care assessment, withdrawal and recovery program for alcohol and other drugs. With me is one of my other co-founders, Dr. Chris Davis, who's our medical director and GP and addiction consultant with a special interest in addiction management. And most importantly, our very special guest we're absolutely thrilled to have with us is Dr. Carl Erik Fisher. So Carl is an addiction physician, bioethicist, and person in recovery. He's an expert in addiction and recovery, and he's sought to make sense of topics like self-control, suffering, and behavioral change across not just science and medicine, but also looking at history, spirituality, philosophy, politics, arts, literature, and more. And I think is uniquely positioned to share ideas and practices that help people flourish in their lives. He's the author of an amazing book, which I encourage anybody to read if you've not read it yet. It's absolutely fascinating. It looks back at history of addiction and was published last year, very rightly named one of the best books of the year by the New Yorker. So as we go through today, strongly encourage you to drop any questions you have for Carl in the Q&A. We'll keep a track of those. We'll tackle some as we go, and others we might pick up at the end. We're going to try and leave time for discussion. But I'm going to shortly hand over to you, Carl. I mean, congratulations on The Urge. It really is a fascinating look back at addiction through the ages, from before even the term addiction was coined. I was really interested early on in the concept of akrasia, so this idea of acting against one's better judgment, which was debated, I think, several hundred years BC. As someone with experience of alcohol dependence myself, I would definitely side with Aristotle over Socrates and say it's a thing. It happens. I really believe in it. The book covers a wide range of topics and perspectives on addiction that I know we're going to get into, but I wonder if we could start with your own personal experience of addiction and recovery and how that inspired you to write the book.
Yes, absolutely, Pia. Thank you. And thank you, Pia and Chris, for having me. It's a real honor. And I always love speaking to audiences that deal directly with the problem of addiction in all of its varied forms, whether it's people in the most severe inpatient clinics to people on the front lines dealing with the mildest substance use problems and all the rest. It's a real privilege to talk to people who have differing experiences of addiction around the globe. And I would really encourage you to ask questions, to think of questions and drop them in the chat, because I really think that's a lovely way to use this time together. I'd really echo that. Excuse me. So it answered your question about my own experience of addiction, just to give you a sense of where I'm coming from. First off, as a person in recovery, it was a little over 10 years ago that I was graduating from medical school, and I thought I was on top of the world. Essentially, I was graduating from Columbia Medical School with several awards, and had already started publishing in the academic literature, and had envisioned a career for myself as a star. I just wanted to be a striver, a grinder within the academic medical system. And all of that frantic activity was, in a sense, trying to compensate for a long, long simmering problem with alcohol that up till that point had never really come up high enough to interfere with my work functioning, but had certainly caused me problems with my relationship and with my families. And it all started coming to a head once I graduated medical school. So I did my internship and my residency at Columbia Medical School as well in psychiatry. And as time went on, I started getting these little incursions of substance problems into my work life. Before I had set limits with myself and blown through them, or had problems with stuff along the margins. But at that point in residency, I started to wake up late. I started having to cover up for myself. One time I remember waking up on the floor outside of my apartment. I was in a New York City tenement style apartment, and I woke up without a shirt on, and I remember my skin sticking to the linoleum floor outside of my door, and having to climb up the emergency exit and then back down through the fire escape. Just rushing uptown to 168th Street, like I had done so many times before, like very hastily brushing my teeth and trying to cover up whatever smell or whatever outward evidence I might have of my substance problems. And still, I was sort of frantically trying to cover it up with achievement. And that was part of my addiction too. This is an important theme of the book, is that addiction is not quite so binary as it's commonly been portrayed. That all of that striving to distinguish myself and to want to be the best and to want to be at the top no matter what was also part of my addiction. I needed external validation to feel okay. I needed to look at the world in terms of what I could get. And if I didn't get what I thought I needed, then I wouldn't be safe and I wouldn't be okay. And that very directly related to my addiction too, because as things progressed for me in residency, I went out and I got Adderall. And in my case, I went and I did that. Oh, and by the way, this is mixed amphetamine salts. I don't know if it has a different name in Australia, but same category as Ritalin. And in my case, I went out and I just went to a friend of a friend, general practitioner, and I remember actually one of my doctor friends had mentioned, oh yeah, this person seems kind of like open-handed with medications, and he just offered me Ambien or benzodiazepines just right off the bat, and that's why I selected him. And I went in and I said, hey, listen, when he customarily offered the Ambien or other sedatives, I said, no, that's not really my problem, but I would really love to have some sort of stimulant on board because I'm really tired on the weekends and I'm trying to distinguish myself as a bioethicist. And he said, well, we have to consider this off label, but I'm okay with that, just use it responsibly. And so he prescribed me Adderall, and then that was added to the mix. And very quickly after this point, I actually had a sort of an intervention with my residency program, which was notable in the sense that it was conducted by people I had known for years and years and years. I knew that I wanted to be in psychiatry research for a long time. So I knew the residency director and the assistant director, and I trusted them, and I knew that they were thoughtful, compassionate leaders, and they stood by their word. And so when they called me into their office and they said, we think you have a problem, we don't know exactly what's going on, but we want to let you know that there are confidential mental health resources, and there's a firewall between us. Nobody has to know the specific nature, but we really think something needs to change with you. Despite the fact that I was very, very clear on a logical level, and Pia, this gets to your point about acrasia. Despite the fact that on a logical level, I knew that it was safe and that I would essentially be okay, there was still some sort of elemental denial that rose up in me, where I thought, I have to hide this drinking problem no matter what, that if I have to make a change, I would die. That wasn't a concrete and well-formed thought in my head, but it was the feeling, it was the sort of instinctual response to the notion of changing my drinking patterns. So I covered it up. I lied to them and I said, I know what this looks like. You must be worried that I have a substance problem, but I can assure you, it's just a tough adjustment to residency. I'm in therapy, which is also a lie, and I'll work on it. So I went out and I was able, through what I consider to be willpower, which in itself is a sort of sloppy concept philosophically. But I thought through willpower, maybe I could discipline myself. I set drinking goals for myself, put a calendar up on the wall, started tracking my drinking, all entirely by myself, 100% by myself. And it worked until it didn't. It worked until I got to, thankfully, a break, a vacation in my residency schedule. It started to fray at the edges before then, but I was able to tell myself it was okay. But on that vacation, I went on an alcohol, Adderall, and cocaine binge that left me in a manic episode. So the first time in my life. Not clear if there's bipolar in my family. Never had one since, more than a decade prior. But I had just taken enough substances and been sleep deprived enough that I tipped into full florid mania. So running through the streets of New York City, beset by spiritual delusions, thinking I was in a holy war of good versus evil. Wound up at one hospital actually after a syncopal episode, because this is a more medical audience. This is nice for me because I get to use more of the medical language. And did an EKG, saw some abnormalities. They were worried I might have Brugada syndrome, in fact. So they recommended a Holter monitor and longer monitoring. But I also knew they could maybe get the word back to my residency program, or maybe somehow through the rumor mill, or maybe there would have to be some official disclosure. They would notify my program that something was up with me. And so I signed out against medical advice. And I thought maybe I could, even in the grips of a fluctuating mania, I thought maybe I can control this. Maybe I can do it by myself. Where that led me is to a worse episode where it was fully psychiatric, in the sense that I was screaming in my apartment, completely terrified, worried that I might kill myself, not even wanting to kill myself, but so delusional and so out of touch with reality that I started yelling out for help. And by virtue of my privilege, by the fact that I'm a white man, at the time I was living in a wealthy area of downtown New York, the New York City Police Department came to get me and treated me very nicely. They did have to tase me. They did hit me with the taser, but
it doesn't sound very nice then.
It wasn't nice, but it was just very compassionately done. A guy came in and said, "Hey buddy, are you gonna come along nicely?" And I said, "Probably not." And so he shot me with the taser. But I was taken, rather than being arrested, I was taken to the hospital, and I wasn't beat up and I wasn't shot. And
a lower bar
from that point on, it was handled
nice.
Reasonably well. And that's the story of how I got into treatment, and that's the story of how I got into recovery. I was really lucky. At that point, I was able to enter recovery, and I was we can go into more about this in question and answer. I don't know how relevant or interesting it is for physicians abroad, but in the United States, there's a physician health program where you're monitored and you have to do urine tests. But the real story of it all was I had a moment where I said, I'm an alcoholic and I need help. I'm an alcoholic like my family, like both of my parents, like my grandparents before me, the majority of my grandparents, and I need help. And then, even after being in the inpatient psych ward, I saw my resolve fluctuating. And I saw sort of doubt and denial rise up in me, even though primarily I wanted to stay abstinent and in recovery. And so I thought to myself, this is urgent. Like, I really need to make sense of this. And when I went to rehab, and when I got exposed to some of the traditional older school confrontational practices that are prevalent in the United States in particular, I think we're probably outliers, although it's spread through our own process of intellectual globalization throughout the world. When I saw some of those practices, I didn't get what I needed in terms of making sense of what had happened to me. I was was okay with the notion that I had a problem, that I was an alcoholic, and that I needed to make significant changes, but I didn't have an answer for what had gone wrong in me. And when I looked to science, which is my traditional home, and which is something that I still think has a lot of good, and there's a lot in the science of addiction that is really, really helpful, and I still draw on it in my work and in my writing. But it didn't have a good answer for that question, what had gone wrong in me. It had 30 different answers to the question. There are many, many theories of addiction. There are warring camps, and they're usually useful that they seize on one small piece of the puzzle. Here's a behavioral economic perspective on addiction, or here is a Freudian psychological picture of addiction, or here is some sort of environmental and sociological picture of addiction. What I wanted was a more overarching and synthetic account of addiction, and it wasn't there. And that's what motivated the book. That's what motivated me going ahead and writing the book. And I'll leave it there. I mean, there may be questions and there may be things coming into the chat. Once again, I want to remind people to please put in questions in the chat. But Pia and Chris also teed up some points about selected topics from the book, like the nature of epidemics and the intellectual history of addiction over time. And, we can dip into that. This doesn't have to be a lecture. It doesn't have to be all monodirectional of me talking the whole time.
If you don't
But
mind,
we may dip into it a little bit.
I mean, one of the fascinating things for me, certainly when you were in the practitioner health program, and we've got a similar one here in Australia, and I've helped a number of my medical colleagues through that. We know that contingency management. I mean, when people think of contingency management, they generally think of getting food vouchers or money for negative urines, but certainly in the book you mentioned how practitioner health programs and pilot health programs have very good success rates because it's their job is contingent on them finishing this program, and yet despite you had this sort of real big sort of carrot and sort of need for you to be in recovery and in the program you were in, it took a while for you to have that sort of, I don't know if light bulb moment is the right way of saying it, but when you say you gave yourself over to the program and the denial and the sort of resistance sort of ended. I found that part of the book really interesting because if as counselors and psychologists and doctors, and I don't know if there is any light you can shed on how we get people to that point. And I know we talk about motivational interviewing, but was there something that helped you switch at that point? Does that make sense?
Yeah, it's a good question, and it really is mysterious to me in the sense that I didn't do it myself. It wasn't some logical or intellectual point I reached in terms of making sense of my own identity. And what Chris is describing essentially is that I was in the program and I wanted to be compliant in the sense that I didn't want to lose my job. And I was on board with the notion that I shouldn't drink for 5 years because that's the length of the monitoring contract in most American jurisdictions. But I had seen many, many people go through that program and then start drinking after year 5. And that was frightening to me in 2 ways, at least. One way is that I didn't want to lose sight of the problem and be lost again to denial. And then just, people would be readmitted to that rehab, the special doctor rehab for the second time, third time, even fourth time, at 5 years and 5 days. They would go on a bit, and this is not to make light of their condition because it was really terrifying in some cases, but 5 years and 5 days later, go on a binge, wind up back in the same place multiple times. I didn't want that to happen to me, but I also didn't want to just sort of stumble along through life unexaminedly and not have a sense of who I was and what I was in relation to alcohol. And so, again, that was part of the thing that motivated the book, was a question: how do we make sense of addiction if some of the standard narratives don't necessarily make sense? If this sort of standard stereotypes of like addiction is a brain disease and you have a broken brain, or once an addict, always an addict, or your disease is always doing push-ups in the parking lot, et cetera. Like we all know the cliches. In some of those stories, which again were given to me in treatment settings, were not ultimately satisfying, in part because there's scientific evidence that some people can have severe alcohol problems and go back to moderation, or other sort of challenging pieces of evidence. If those things are true, then what happens? And I think, the initial response, getting to your question, Chris, like the clinician response is often, don't worry about that. That's intellectualization. Don't think about these sort of alternative conceptions of substance use problems, because maybe that'll be dangerous and you'll be seduced into relapse or undermining the notion of addiction. I don't think that works in 2023. There's too many podcasts and Substacks and the AA critical books. There's enough like explicitly anti-addiction, anti-AA, anti-recovery narratives out there that we need the honest middle ground of acknowledging some of the counter arguments. And I think, like motivational interviewing, it's meeting people where they are in terms of their sort of doubts or explorations of alternative conceptions of this identity, and then allowing people to come to their own conclusions, because that's what happened to me. I had to sort of reject what felt to me like a dry, sort of ossified and rigid narrative about addiction to allow for a more capacious idea about addiction. And so I came back to the notion that I do have addiction. Whatever addiction is, I have it. I don't think that it's a rigid disease that's set off from the rest of the population, in the sense that there's addiction in all of us, even at a scientific level, that some of the psychological functions that subserve addiction or that create a vulnerability to addiction, even at a basic level like temporal discounting, those problems are present in everyone. And there are people like me who are far enough out on the spectrum that we need to be extra careful. And I'm not interested in running the experiment of, could I do moderation again? There's this problem I discussed at that point in the book called The Problem of the Heap in philosophy that really spoke to me. And it's really about boundary drawing, and it applies very nicely to conceptual work in psychiatry. Psychiatry, my home discipline, has all these questions about, what counts as a mental disorder, what's the line between so-called normal and illness. And we've traditionally dealt with very categorical, bright lines, because that's what insurance companies ask for, and that's what researchers need in a certain way, operationally, in the way they conduct research. But in reality, it's more of a spectrum. And the problem of the heap is, if you have a pile of sand, it's a heap of sand, and you start removing the sand grain by grain by grain, at what point does it stop being a heap, or vice versa? There's no strict line. And yet a big mound of sand is a heap, and one grain of sand is not a heap. So there is a point, you can meaningfully say, hey, there's a heap there at some point, even if you can't draw a stark line in between that. And I think addiction is like that. I don't know that I can draw a strict dividing line between myself and the rest of the population, whatever that means. But whatever it is, I have it. And engaging with some of the philosophy rather than the science, actually, in this case, was helpful for me for getting comfortable with that notion.
Yeah, I mean, what's the difference between a small heap and a big heap, and the difference between a mild substance use disorder and a severe, and at what point are you now? And if you've not had a drink for a week, do you still have severe? It's where you draw the lines in that heap of sand is really interesting. Maz has put a question in asking about how long your recovery program was, and was it a therapeutic community? I think I'm probably hijacking that question a little bit, but I was asked by someone that I was having lunch with this week, when I sort of intimated there was no cure for addiction, and that was really upsetting for them. And when I started talking about recovery and how we're all human and you can't cure being human, it didn't really it wasn't really the answer they wanted. People want a cure, and I think if you can be reductionist and say it's a brain disease and here is the pill that will cure you, it sort of fits
Yes.
people's ideals of disease a bit nicer.
Well, I've got some language for you on that, because that tends to be a message I want to reinforce. So even if we don't get to the slides, I have a sort of concluding slide that we can come back to. Yeah. My recovery program was, the way it's set up in the United States, it actually varies by state. So I'll just talk about New York State. And New York State is pretty common, but there are variations regionally. The American West, for example, is a lot different from the rest of the United States in terms of the way it treats mental disorders. In New York State, there's a medical board, which is the medical organization, and there's the Office of Professional Medical Conduct, which is run top down by the government. The Office of Professional Medical Conduct is the government's arm that's interested in tightly regulating doctors who have gotten into trouble. And so they tend to be quite punitive. But then there's also the medical board is organized by the medical organization, and that's a voluntary advocacy program. But it still has some teeth. So if you voluntarily enroll, or if you're encouraged to enroll in the medical board side of things, which is what I was in, then they have some teeth in the sense that if you leave it, then they're obligated to report you to the government. And so there are contingencies in place to prevent people from wavering. And if people try to disenroll, they're subject to consequences. So it's 5 years. And the 5-year monitoring contract is traditionally regular urine tests, some sort of worksite monitor, and some kind of therapeutic arm. And all 3 of those things have a line of informational disclosure to the monitoring agency. And so they keep track of people for 5 years. Notably, the urine monitoring includes ETG, so they monitor for alcohol. Obviously, people try to evade that. They go away on vacation for 5 days. They drink hard for the first day, and then they try to let it wash out of their system. But I also saw plenty of people in the rehab for doctors who were skirting around the edges, and the 1 day became 2 days, became 2.5 days, and then then they got detected, and then they wound up back in rehab. And then after those 5 years, upon successful completion of the program, they write a letter. And this is where the advocacy part comes in, is, the organization, the PHP on the medical board side, is really interested in supporting doctors, and they want people back to work, and they want people back to work safely. And so they, once I completed that program, they wrote me a letter. And so the state of California is actually sort of an outlier in the United States too. We could go into California is a fascinating place, but I was trying to get a medical license in California, and traditionally it's one of the worst places in the United States to get a medical license if you have a substance problem, in part because there's this long history of grassroots advocacy, and they can write these things called propositions, which is a sort of like public referendum where the public votes something into consideration by the legislature. And they were very supportive of me getting a medical license, and I was able to get it, which is sometimes very difficult. They wrote a letter saying, we've monitored this person for 5 years. We have the receipts. We have urine tests in a high quality forensic chain of custody. We have a lot of experience running these types of monitoring programs, et cetera. So that's the way it was. It wasn't a therapeutic community. I mean, therapeutic community, I have a whole chapter in the book that talks a little bit about the history of what therapeutic communities are. TCs in Europe and primarily the UK have a different sort of lineage entirely than what has come to be called a therapeutic community in the United States. The origins of therapeutic communities in the United States actually come out of a cult called Synanon, which was sort of Scientology-esque, where in the 1950s, there was a sort of charismatic and wild man who, and I won't go too far down this rabbit hole, but kind of was frustrated by AA. He was abstinent in AA, but then was kind of frustrated that he couldn't give more advice, and he couldn't be more of a leader. He wanted to be like the president of AA, and he wasn't able to be. And so he went out and started his own group, where he started like a rickety Santa Monica storefront, and he had all these young people trying to get into recovery who called him dad, and it blossomed into a cult where people eventually had to shave their heads, and men and women were separated. There were awful instances where, you know, children were separated from their parents, and just a lot of coercion about women. Like the gender dynamics there were just awful, like terrible abuses. But it made extremely powerful connections and started a chain of treatment programs based around harshly confrontational methods, like a hot seat where there's somebody in the middle, and then everyone around the periphery of the group therapy is like sort of like hurling invective at the person there, and so forth and so on. And that actually became professionalized and is very directly the intellectual root of a lot of treatment programs in the United States. And when I say harsh, I mean this cult Synanon had a military arm. They were called the Imperial Marines, and when they had critics in the community, like journalists, they would go beat them up, and they sent people to the hospital. And one guy got a rattlesnake in his a rattlesnake with the rattle removed. This is the especially terrifying part of it. They removed the rattle of a rattlesnake so it would be more stealthy, and then they put it in this journalist mailbox. So then when he reached in and he got his mail, it boom, struck, and then he had to be taken to the hospital and get multiple vials of anti-venom. So anyway, all of that is a little tangent to say therapeutic communities in the United States
heard of any of those
have some problems.
Approaches in Australia or the UK. I was fascinated by that in your book. I just thought that sounded absolutely. I mean, people are scared enough to join a group therapy session if they thought they were just going to be abused. I don't think anyone would ever go.
Yes.
We've got some brilliant questions coming in from the audience. Simon has asked, and this is an interesting question for the Clean Slate cohort, whose goal is often not abstinence. Often these are people who have not been through detox or treatment before, and really just want to regain a bit of control, and they do want to moderate drinking as their initial goal, and sometimes that goal changes and they want to become abstinent over time. But Simon's asked, he says, "Hi Carl, what percentage of those with long-term alcohol issues does the evidence say can possibly succeed with a moderation controlled use approach?"
Yeah, it is a great question. You know, the best recent research on this, to my mind, is by Katie Witkowitz, who, if you're interested in the more academic side, you can trace back the citations of my chapter 11. You know, I intended for the book to be usable by professionals and academics in the sense that the main text is readable, but there are a lot of footnotes, and it describes the studies in more academic detail. The percentages are a little wonky. I mean, there have been important studies on this since the 1970s, continuing to this day. And part of it depends on that initial part of your question. So long-term chronic alcohol issues. Long-term chronic alcohol issues has been defined in different ways. And the standards people used to measure that, say, in the 1970s was essentially just a sort of gut sense of the clinician saying, oh, yeah, that person's an alcoholic. And then it's evolved more to more structured DSM-based definitions of severe substance use disorder. But even in the more recent studies, you'll see percentages of, say, 40, 50, 60%. I can't give you a percentage right off the top of my head, but, you know, in the range of half of people who return to moderation can do that. And I think even more interesting is the majority of people who return to moderation or low-level use without serious functional problems do so without medical intervention.
Yeah.
There's a huge percentage of people who just age out. That's true in other substances too. That's true for opioids. The percentage is much lower, and like especially with our poisoned, contaminated opioid supply, certainly in the United States, but increasingly around the world, like moderation is a much less viable option. But there's always that percentage. And, you know, just briefly, that's what I was talking about in reference to Chris's question earlier, is given that there's a percentage of people who can return to moderation, what does that mean for me? Yeah. Because I had one extremely awful incident where I wound up in the psych ward, and then I had a chain of work problems, but they didn't rise to the level of even formal sanction. It was basically just that my immediate supervisor was starting to get frustrated and worried. Why are you coming in late? You seem a little grumpy on certain days. You're mouthing off to your superiors, etc. and then internally, I knew I had a deeper problem stretching back at least to college that manifested in more subtle ways. And so given that there's this huge percentage of people who can return to moderation, why can't I be one of those people? Is it possible that I could be one of those people? And for me, that had to be a very personal, subjective determination. What is it worth to me? And what is it worth in regard to who I think I am? And I see clients in psychotherapy where it is extremely meaningful to them that they test this hypothesis. Maybe I can embark on controlled drinking. And maybe the importance of testing that hypothesis is not very workable. It's not actually all that helpful to them. And I can look from the outside and say, I wouldn't make that choice. You know what? You know, this is potentially life or death. You could lose your driving license. You could lose your medical license. Why bother? But I could talk till I'm blue in the face. If somebody has that firm of a sense of self and a specific attachment to that view of themselves, then I think that has to be approached very gently. And a lot of what is addiction in the sense of the personal sense of powerlessness can be differentiated from substance use disorder. A substance use disorder is a diagnosis from the outside. But I think addiction and sort of signing up for this life of abstinence and what some people call sobriety is much more of a subjective, internal, personal determination. So I think it's a crucial question for a lot of people out there who you know, they read the literature, they read popular accounts, and they say, you know, like if there are people who go out and they moderate them, why not me? And that's a tricky one, but it's not one that we as clinicians can dictate from the top down.
Yeah, exactly. I hear you. And certainly it's the DSM, which it doesn't differentiate either. You know, it has substance use disorder, but doesn't have a diagnosis for addiction or even dependence.
Exactly.
Yeah.
I love these questions. I would be very happy to just go ahead and answer the questions. It's more of like a conversation and seminar, and
this is one which I like. You might not have been asked it before, and I hope it doesn't put you on the spot too much, but this is from Sarah Ferguson, who has asked, if you were to select only 2 words to describe yourself in the midst of your alcohol and Adderall addiction, what would they be? And to give you a heads up, the next question would they be the same 2 words you'd use to describe yourself today?
Yeah. Ooh, you know, the first word comes immediately to mind from my gut. It's not, I don't have to think about it. It's lonely. I know this because part of writing the book, I was lucky to get a writing residency, and I went away for a month to a cabin in Wyoming and took all of my journals with me from that time, because I was always an unquenchable journaler. I would be writing by myself, setting limits for myself. What's wrong with me? Do I have a problem? You know, last night my girlfriend told me that she was worried about me. You know, maybe she's getting too needy, or or maybe she has a point, whatever. And it was all me trying to figure it out myself. And I read all those journals in the Bighorn Mountains in Wyoming, and I had such a powerful experience of seeing that boy, you know, even 27, 28, 29 years old, just a boy who was so scared and alone, like he had to do it all himself. And that was really the most visceral feeling I had in terms of re-inhabiting that state of mind. And I mean, that's the only word, really. I don't even know that there's a second word that even compares to it. Scared. It's basically a variation of the same thing. And they're definitely not the same 2 words today. You know, like I still have a lot of problems. There are ways that my addiction, like I said, you know, I believe very firmly that addiction is a human universal. You know, recently, now that I'm 42, having gone through COVID, you know, a lot of it's manifesting in terms of sugar and eating, you know, or overwork or anger, snapping at my partner, snapping at my kid. I think those are not distinguishable from addiction. They're not addictions in the sense that I necessarily am going to go to Overeaters Anonymous, although I know people who do that, and I have immense compassion for people who do. But there's no bright dividing line. That's the same kind of acrasia that Pia mentioned before. This old Greek philosophical conception of being out of control, of just not being able to follow the good. I know what the good is. I know what I want in my heart, and yet still I don't do it. That's a universal human fact. So I still have that, but I'm not lonely and I'm not scared. So how would I describe myself today? 2 words? I don't know. I kind of, I want to be flip about it. Today I feel busy, but connected. I feel busy and connected. And that's a good place to be. Sometimes the busyness feels like a burden, but it's not. It's really nice to be connected and to be working on these types of issues.
I love that. And there's 2 questions I think we've sort of touched on. Vanessa's just asked about the different, in psychiatry, is there a difference in terms, addiction and substance use disorder, or is it officially just substance use disorder? And then she's asking about process addictions, I think food addiction or
yes,
behavioral addictions.
Yeah, there is a difference. In psychiatry, it's the DSM-5. It's a diagnostic and statistical manual that defines mental disorders for research, clinical work, and insurance reimbursement, all the rest. And that's a substance use disorder. That's not addiction. The word addiction shows up in that manual. There's like an overarching section name where they sort of gesture toward addiction, but addiction as such is not firmly defined. It's not a diagnosis that you give someone. Substance use disorder is a diagnosis from the outside, or at least it can be. There are some subjective criteria in the sense that somebody is drinking more than they want to, essentially. But there are also objective criteria where you say somebody is experiencing consequences from substance use problems. You don't need to know anything about a person's internal life to say, hey, this person has problems. Somebody shows up in the emergency room or somebody shows up in the hospital as a direct result of their alcohol use. Okay, there's a consequence, and so forth and so on. Where at least process addictions is, I guess the point of that is, and I think it's useful, and I think this is a clinical approach that a lot of people do, and that I also think is useful, is that addiction is a subjective personal choice. It's an identity that people acquire, just like recovery. One of my favorite recovery advocates here in the States, Jan Brown, says you're in recovery if you say you are. There's all this like line drawing about recovery. Does it need to be this? Does it need to be that? Does it need to be fully abstinent? Does it need to involve citizenship or morality? No, people are in recovery if they say they are. That's a personal choice, and it's a direction, it's an intention that people embark upon. But substance use disorder, you can say at least somewhat objectively. So process addictions, gambling disorder is in the DSM, and that's new. And rightfully so, because gambling is the first addiction I found when I looked at the history. There's a poem from the Rig Veda from 1000 BC in India and South Asia, where there's a beautiful description of a man who's out of control regarding his gambling. And to this day, some of you might know, gambling disorder has the highest rate of suicide of any of the addictions. And if you take a moment and you think about that, you can imagine why. People can lose everything and feel it's inescapable, especially nowadays with online. I don't know what it's like in Australia these days, but in the United States, more and more and more every day, apps like sports betting, it's just inescapable. Crypto, it's everywhere.
Yeah. And
it's everywhere. So gambling is there, but we don't have official diagnoses for food, sex, all the rest. There are people who advocate for that, but it's not in the diagnostic manual yet.
There's another couple of questions which I think are related. An anonymous attendee's interested in our thoughts on addiction and trauma, that they think trauma has become such a big focus we don't look at other things, and certainly you mentioned this in your book, and it sort of comes on to the next question, but everybody's situation is so different, and so I guess the reason people who drink or take drugs do it for a reason. I think I'm quoting you maybe even directly, but there's reasons why people do it. And we sort of need to work out what those reasons are to work out the best way to help them. And that comes on to sort of another question, which says, and which is a fascinating part of your book, and something I hadn't really been aware of, was what treatment helped you the most. And I can't remember the official name for it, but it was internal family therapy or
internal family systems.
Internally family, yeah. And I know that really resonated with you and was helpful.
That's right. That's right. Yeah, internal family systems is increasingly used for trauma. Internal family systems is a relatively newer psychotherapeutic modality, really pioneered by Richard Schwartz, who formerly was at Harvard and is now an international sensation. And so it's become very popular very quickly. And, you know, there are a lot of sloppy implementations of IFS as well. It's sort of become trendy in the same way psychedelics and, you know, mindfulness 10 years ago, you know, we ride these, and trauma now, you know, there are these waves, there are hype cycles in mental health treatment where people become too focused on one particular thing. That's true in academia too. You know, my perspective on trauma is it's immensely important and it's long been overlooked. And I agree with you that now it's become sort of a one note focus, as if trauma is the holy grail. And if you would only resolve your trauma, then all of your problems will go away. And we have an addiction in the field, speaking loosely, to monocausal explanations. That's one of the big themes throughout the book. And that goes back hundreds of years. Addiction is one of the most complex and mysterious problems that we face as a human species. It's not even necessarily a disorder. It's, I think, like, if I'm saying it's universal, then I think it's one of the most fundamental behavioral puzzles that we have. And so because it's deadly and ruins lives and ruins the lives of families around them and all the rest, people are desperate, grasping onto answers. And we tend to bounce from monocausal explanation to monocausal explanation. There was a period of time in the 1970s where it was all about neurotransmitters. And then in the 1980s, people were really focused on genetics. And out of the 80s and 90s, we still have the intellectual legacy in academia and in the popular discussion that there's a gene for addiction, or that it's predominantly genetically driven, which is false. Genes are very important, but it's at most, it's about half the puzzle. The environment is at least on equal footing in terms of the causes. And then more recently, we've neglected trauma for a long time, and now there are a lot of people who are sort of uncritically going out there saying trauma is the magic key. You know, this is the overlooked thing that if you solve it, then you'll be fine. And that's just not the way things work in complex mental health problems. I think the sort of rigorous conceptual description of all mental disorders, but especially addiction, that works really well is to be pragmatic and pluralistic. Like, pragmatism is about what works. Pragmatism is just like, what is useful here today in this moment? Pluralism means, rather than eclecticism means I'll learn a bunch of stuff and I'll do what I feel like, or I'll do what the person feels. Pluralism means, can you hold multiple models in your head simultaneously and deploy them thoughtfully and mindfully for the problem at hand? In other words, when I'm practicing as a psychotherapist, for some people, I'll be very, very focused on skills-based training and mindfulness-based practices, but also other sort of deployable practices in the real world, even to the point of worksheets and programs. And then for other people, I might adopt the kind of training that I learned more in my my residency program, which is more psychodynamic, more open-ended, exploring the past and understanding the self and identity. And there's no one right answer. You just have to be thoughtful and exercise discernment about what the right key is for the different locks your patients are presenting for you, but not to do it in a sort of like slapdash way, like, hey, I'm thinking about mindfulness today, so I'll tell all my patients to do mindfulness. Yeah, I think trauma is like that. I think like trauma-informed care is important, but to attach to like a single explanation like this is the predominant one is just I want to be compassionate about it, because I think people are looking for answers, and people are really desperate, and people have been inadequately helped by the existing predominant models. And so they turn to trauma and they say here, and a lot of people have been helped by attention to this field that's traditionally been underserved. And at the same time, if the pendulum swings too far and then we get too focused on trauma, then we miss out all the other components, which are also necessary. There's a lot to this. I think there's a really good magazine article that I would highly recommend. It's pretty rigorous and well done in New York Magazine, just the magazine New York. Somebody did a long profile of Bessel van der Kolk, who's the author of The Body Keeps the Score. And it's a profile of an interesting guy who had some problems with his clinic in Massachusetts, but it also is a sort of long, deep dive narrative history of the way trauma has been looked at in the American medical establishment. And I think that's a really useful, even-handed background of the discourse. Just what is the actual history of ideas of trauma within medicine and the general public.
Yeah, no, that's right. Fantastic. There is I guess if we're talking about hype cycles, psychedelics are very much in the press. We're at my hospital, St. Vincent's, we're doing the CYMA trial, which is psilocybin for people with methamphetamine dependency, with good results. I mean, it's a very small trial, but people are doing well. And Maz has asked about the latest trend with treating mental health conditions and indeed substance use disorders with psychedelics. And I mean, one thing which has come out of our small study is that often people, particularly with crystal methamphetamine dependence, can be in therapy for 2 years and need quite intensive therapy and can do very well. But perhaps if we can speed it up by doing sort of 4 or 5 hours of intense therapy with 2 therapists with psychedelics assisting that, then it can save money and time. But it's going to be very expensive and is still, unfortunately, although extremely exciting, in our experimental phase from what I can gather. Do you think magic mushrooms will help our drinkers one day?
I think there's a lot of promise there. I'll just say briefly that my read on the scientific literature is there was a lot of enthusiasm from the first wave, like the Michael Pollan era of psychedelic work. Very, very strong outcomes, and for example, in people facing end-of-life distress, people with terminal cancer diagnoses, massive changes in their outlook and their psychological functioning. And then and there's always been interest in psychedelics and mystical experiences in general, or just engagement with spirituality, whatever that means to people in their addiction treatment. And so there's a lot of excitement for using psychedelics in the treatment of substance use disorders. And those results are some of the follow-up larger studies more recently, like Bogenschutz at NYU, have shown a treatment effect, but nowhere near the same magnitude. It hasn't been as exciting. The treatment sizes and the rates of remission and recovery are not as large as people had hoped for. And I think part of the reason for that is addiction is messy, it's complex. A lot of people have really severe issues, and psychedelics are not the single answer. Maybe, like Chris, exactly like you said, maybe they can accelerate the process, but the idea that somebody will go away to an ayahuasca retreat and then be cured, I think is really dangerous. So we have to be very careful about the way those technologies are used, and not filter them through an overly reductionistic narrative where we think that the substance is doing all the work. I take the mushrooms do their magic on me, and then I'm better. In that way, we just reify the psychedelic. I actually have a small podcast, and I did an interview with Elias Dakwar, which I think, he says it better than I ever could. He's a researcher at Columbia who has studied psychedelics and done trials with ketamine, because ketamine was the legal thing you could do before, and now is doing other work. But he has done some interesting work where he does a psychedelic experience plus or minus mindfulness-based recovery prevention, so MBRP, and it trains people in meditation and other types of mental practices before, during, and after the psychedelic experience and gets better results. Because it's not just about taking it's also about the preparation. It's also about how you work with your mind long term. And what does the psychedelic give you so that you yourself can go out into the world and work with your mind. And that's really important, especially, especially for people like yourselves and the people on this webinar, because you'll see a patient and they'll ask you offhand, 2 minutes, hey doc, what do you think about psychedelics? And I think if there's anything you can tell them, it's really important to dispel that notion of a magic solution and just say it can be useful. This is what I would recommend. It can be useful as part of a comprehensive, holistic perspective on what do you need, what are all the different dimensions of your recovery, whatever recovery means to you. That's the message that I think is getting obscured in the contemporary psychedelic hype.
Yeah, I think there's a lot of hope there, isn't there? And which is good. And I think one thing that when I was talking to the researcher about our trial was that in a way they were sort of self-selecting as a group because they were people who had researched psychedelics and were interested and wanted recovery and yeah, I guess they showed some.
We're low on time, so I wanted to. I'm sorry to jump in, but I just didn't want to hijack. This is my final slide, so here's the slide I'll show. I'm glad we didn't go into this slide. I've got some historical images and photographs and things like that, but you can see it in the book. But this is the way I frame the takeaway regarding what you were talking about earlier, Chris. Like if addiction can't be cured, if there's no quick fix, if there's no solution where you're done with it and then you move on with your life sans addiction, then what? And this is the way I frame it, is that addiction is one of the most fascinating, complicated problems in all of psychiatry and medicine. I believe that. I actually love addiction, and I'm grateful for the ways that I've encountered addiction and worked with addiction in my life. If it weren't for the problems that I had, I wouldn't be engage with all the nuance and richness of all the different ways addiction shows up in my life and my client's life. There's no way to eradicate it totally, but here's the payoff. The payoff is once we abandon the quick fixes and the simplistic answers, that frees us up. So we're shedding the burden of this attachment to a simple answer, and that allows us to see the whole range, the whole pluralistic range of solutions and problems, to respect and care for the full range of this mysterious, deadly, and deeply human phenomenon. That's all I wanted to say, is that I think it's liberating. It's liberating to say that addiction is in all of us and we'll never get rid of it, because it's liberating to get rid of the stories we tell us about reality and just be directly in contact with reality itself. And that's what I encourage all of you to do. I really enjoyed this. If there's any closing thoughts, I don't have a hard stop or anything, but I just want to say I really deeply respect the work you're doing, and I'm really glad to be here.
No, thanks, Carl.
Thank you so much, Carl.
Pia tasked me with summarizing the talk and the book, and actually you've just done that incredibly well for me. I think we do look for simple answers to complex questions, and often there are no simple answers, and that's, I guess, where the richness of our work and our lives comes from. Thanks for asking some pretty difficult maybe questions, and for your introspective and your wisdom. Really appreciate it. So thank you very much.
Thank you. And thank you so much, everybody, for joining. I mean, there was a bunch of topics that I think are fascinating in the book. I really wanted to talk about epidemics, and I think it's because of my own lived experience, where you start by internalizing your addiction as a you problem, and then you look at you learn, you get into recovery, you meet other people who are like you, and then reading the book, you realize this is a 200-year plus problem. So I think I guess my pitch is go and read the book. It's fascinating. The other topic we didn't cover that I think is really important in there is inequity and the imbalance in harm for underserved communities, and starting to think about what we can do about that. But read the book, listen to Carl's podcast, because there's loads more insights in there, and pragmatic and pluralistic. That's my takeaway from all of this. And we will go away as Clean Slate and challenge ourselves to make sure that that's what we continue to do every day. So thank you, everybody, for joining us. A recording of this will come out to everybody, and thanks, Carl. Thanks, Chris. Absolutely fantastic session. Wonderful.